Hey folks, welcome to the AABIP podcast. This is Samir Avasarala from Case Western Reserve University School of Medicine in Cleveland, Ohio. I'm your host for this episode. Thank you all for joining us today. It'll be an interesting discussion that underscores a lot of the work we do, interventional pulmonology and thoracic oncology. Today, we are very fortunate to have Dr. Scott O join us. Scott is an interventional pulmonologist at UCLA and a professor of medicine at the David Geffen School of Medicine at UCLA. Welcome, Scott.
Thanks so much for having me. It's my pleasure to join you today.
Scott, you got any relevant conflict of interest to disclose to us?
I guess I am a medical officer part-time for Intuitive. So I guess that may have some relevance here. So maybe that.
Okay. As a reminder, the views expressed on this podcast are those of the speaker and myself, and not necessarily endorsed by the AABIP. With the formalities done, let's get started. Interventional pulmonology would not exist without thoracic oncology. Like other facets of medicine, thoracic oncology is multidisciplinary in nature, with thoracic oncologists and IP being two very important key players. From a diagnostic standpoint, our goal is to get enough tissue for pathological diagnosis and ancillary testing in the safest way possible. How do we continue to get better at that? Let's find out. Scott, how does IP work with thoracic oncology at your shop?
Yeah, it's very much a multidisciplinary effort at UCLA. We actually have our tumor board, and right after our tumor board every Friday, we have a multidisciplinary clinic that includes thoracic surgery, thoracic medical oncology, thoracic radiation oncology, and interventional pulmonary. And we all see patients kind of round robin style. And, on busy days, we can see 7 patients, and on not so busy days, maybe 3 or 4 patients. But everyone tries to see every patient, and we discuss the case briefly before seeing them to make sure we're all on the same page from our end.
Sounds like a perfect one-stop shop that's very patient-centric. Have you folks been doing that for a while, or is this something a bit more novel?
We've been doing it now, I would say from 2 or 3 years. It was very slow in the beginning. I have to say, from the perspective of from the physician's perspective, it's really inefficient, right? Spending all morning to see somewhere between 4 and 7 patients in a full half-day clinic is not an efficient use of time for any one physician. I think that's a very slow clinic. But it's extremely valuable in learning from each other on the latest and greatest from each of the specialties involved. And we try to reserve patients who are relatively new to the system or relatively complicated for this particular clinic, where it really takes everyone's input to come to a decision on a consensus on what the management plan should be.
Yeah, that makes perfect sense. And, collaboration is key with a lot of things that we do. Now, Scott, I want to get a little bit into the nitty gritty of some of the commonly faced procedural scenarios that center around diagnosis and staging. I want to pick your brain about those. The first thing I want to talk about is robotic assisted bronchoscopy. So let's say you have a suspicious lung lesion with adenopathy. What's the approach at your shop? Do you do the linear EBUS first, the peripheral first, case-by-case decision? What's going on through your mind?
Yeah, it's definitely case by case, but I think things fall into certain buckets. I think the case where we do the peripheral lesion first is if we think it's going to be a challenging case, and if the pre-procedural imaging really gives you a very low pretest probability of mediastinal disease. Those are the situations where you end up finding a bunch of smaller lymph nodes, maybe 3-4 stations sometimes, and you end up spending a lot of time doing linear EBUS to be complete, but your pretest probability is really, really low. In the meantime, you can get all the things that can happen as a case drags on with atelectasis and such. So in those cases, we go for the peripheral first. The other extreme, where you have really suspicious lymphadenopathy and your pretest probability is really, really high, sure. I think I would do the linear EBUS first and then not ever do the peripheral biopsy. If it's kind of in between, I tend to do the peripheral first because usually if there's going to be any challenge, it's going to be the peripheral case that's going to be more challenging than the linear EBUS. So it kind of, those in-between cases, I tend to go after the nodule first.
Yeah, it's a tough decision to make sometimes. You're weighing cutting down procedure time and general anesthesia time for the patient versus potentially maximizing the greatest yield that you can get from any given procedure. So I've been in both boats in that particular scenario. So Scott, let's say you're doing a staging EBUS for a right-sided lung mass and you confirm cancer in station 7 with Rose. Are you assessing other N2 stations to determine bulkiness, or just stopping there after you determine you got enough tissue?
That's a great question. It goes to, how do you know it's bulky disease? And
Sure.
The usual response is, I know it when I see it, right? I think everyone agrees that multi-station N2 disease would be quote unquote bulky disease. So I think once I know 7 is positive, then I really try and go after any other N2 lymph node stations that might be positive as well. And also, I make it a point, our team feels that having, let's say, 2 positive 7 lymph nodes kind of starts to stretch into that area or cross that line into quote unquote bulky disease, where depending on their medical comorbidities and medical operability, may lean us one way or the other as far as going with a neoadjuvant or definitive approach up front. So, once I know 1 and 2 station is positive, I try to be pretty thorough to either completely exclude surgery as an option or be confident that it truly is single station, non-bulky N2 disease, and going with the neoadjuvant approach first.
Mm-hmm. Would you say that was a more recent change in practice, or you've been doing it that way for a while?
We've been doing it that way for a while. We try to look at the lymph node. A lot of times you see multiple lymph nodes at one station. So we look at the ultrasound characteristics and try to pick the ones that we think are the most suspicious.
Okay. My next thing that I want to talk to you about is, let's say you got a Rose call on a parenchymal lesion that's positive for malignancy with whichever needle you're using. Do you always follow the needle with some sort of forceps or 1.1 millimeter cryoprobe, or do you just stick with the needle and get as much tissue as you can?
Yeah, my approach has been needle first to create the pilot hole, usually 2 to 3 passes. Then I put the cryoprobe through, and I do a cryobiopsy pretty much every time.
Okay.
And then get 2 to 3 passes with the cryoprobe and with the forceps. And then I articulate, and target a different area of the lesion, and then repeat. So needle, cryo, forceps, needle, cryo, forceps, until I feel like I've got enough tissue to get all the analysis that we want to get. So that's been kind of our protocol. For really high-risk lesions that are kind of right at the pleura, I feel like the cryoprobe is actually more precise and safer than the forceps, because as you advance your forceps, you don't exactly know how much of the tissue is being pushed around and where you're exactly closing the forceps. And I feel like with the cryoprobe, it tends to be a little bit more precise and in the location and area that you're biopsying. So if I'm, for example, biopsying a pleural-based lesion, oftentimes I won't use the forceps at all. I'll just use the needle and the cryo. Yeah,
the advantages that I've personally seen with the cryoprobe is you don't have to, create enough space that your forceps necessarily needs to open. And I feel it's significantly more flexible than the standard forceps that we would use for peripheral lesions. Now, Scott, let's say you're doing a staging EBUS for a lesion. Pick whichever side you like, and this patient already had a PET CT to begin with, and there's no adenopathy and there's no PET avidity in any of the nodes. Are you taking a look at the contralateral hilum?
It's a good question. I mean, I think the bigger question there for me is, am I going to stage them at all? What's my pretest probability? And if they're really, really small and peripheral and the PET CT is negative, I think the biggest decision is, are you going to do a staging linear EBUS or not?
Sure.
Once you've made the decision that you're going to do it, I think you should either be all in or out. And if you have your scope in, I think it would be, we would do our usual systematic evaluation of every lymph node station, starting from the N2s on the N3s on the other side.
Makes sense. Makes sense. So lots of research is published in thoracic oncology. In your mind, over the last 2 to 3 years, have there been any publications that aren't necessarily considered IP papers that have changed your practice with what you do on a day-to-day basis?
Yeah, I would have to say it has to do with early stage disease, that big category, and specifically the surgical literature and the neoadjuvant literature. For the surgical literature, the CalGB 140503 study with Altori showing that sublobar resection is non-inferior to anatomic lobectomy, both wedges and segmentectomies. Mm-hmm. That to me was a game changer in the sense that you can try to get away with lung-sparing surgery and have equivalent outcomes. But the other eye-opening thing, I always thought that we were doing better with surgical outcomes for lung cancer, but the recurrence rate in both arms was basically 30%, right? And having 1A cancers that had, very good staging, get, surgical resections, and have a recurrence rate of 1 in 3, almost 1 in 3, was, incredibly high to me. So that kind of changed my approach to how important it is to figure out how to treat these early stage lung cancers better, even stage 1A, 2 centimeters and smaller out in the periphery. This was also shown in the JCOG study, looking at the Japanese. And they didn't do wedges. They only did anatomic segmentectomy versus lobectomy. And their disease-free survivals was a little better, with recurrence rates of more in the 15 to 20% range. But I think it's because it's a different disease. I think their cohort probably had a higher percentage of less aggressive adenocarcinomas. So that had impacts on the disease recurrence. But still, having a recurrence rate of that high for curative intent surgery for stage 1A was eye-opening. So I think that we have a lot of room for improvement for even definitive surgical resection of stage 1A disease is kind of sobering data with modern surgical techniques. The other things for early stage disease are all the neoadjuvant trials. I think starting with Checkmate 816, they showing significant event-free survival with a neoadjuvant approach. Was Checkmate 816 was starting in stage 1B, and then that was followed by neoadjuvant and adjuvant studies, AEGEAN, Keynote 671, and NeoTorch, all with the same kind of formula, and that's patients who are eligible for surgery, stage 2 to 3, and then they got neoadjuvant chemo plus immunotherapy, and then the immunotherapy was, the immunotherapy du jour, durvalumab, pembrolizumab, or toripalimab. Sure. That was followed by another year, mostly of immunotherapy alone, and all those studies came back positive for event-free survival. So how that changed my mind of what we do is I used to not care so much about N1 disease because if they're going to get surgery, they're going to get the N1 lymph nodes dissected out, assuming you have a good thoracic surgeon that dissects out the hilum well. And then if it's positive at the time of surgery, then they can go on and get their adjuvant therapy. No harm, no foul that you didn't find that N1 lymph node pre-operatively, pre-resection. But these clinical trials start enrolling patients at stage 2. So if you find that N1 lymph node, they would be enrolled into these trials. So now it's even more important to try and find those N1 lymph nodes preoperatively. So I've become much more diligent and vigilant about trying to find N1 lymph nodes preoperatively to see if they're a candidate for the neoadjuvant treatment. And also the other 2 trials that I think that or kind of groups of trials that are really game-changing for me have been the targeted adjuvant therapies, with the kind of prototype being the ADURA trials looking at osimertinib for EGFR mutated, and then just the reported ALINA trial, which was very similar to ADURA, which is the crizotinib trial for ALK-mutated cancers. And basically what they're saying, what they're showing or beginning to show is that, even for early stage disease, giving people targeted therapy for years after definitive local treatment has significant improvement in outcomes. And all these trials are being now pushed to the neoadjuvant trial. So they're trying to give these targeted therapies neoadjuvantly before resection to see how much of a benefit they provide. So I would say it's that group of studies that has really impacted my practice on a regular basis, and specifically in a way where I'm much more aggressive and thorough about finding those N1 lymph nodes to see how much of a benefit or a candidate they may be for neoadjuvant therapy.
Yeah, with the data coming out, definitely a changing landscape that we need to stay on top of. So I think we can all agree that IP is booming. There's more technology out there, more and more fellowships every year. What do you think the next step is in IP fellowship training, an evolution that can make trainees more involved stakeholders within thoracic oncology as years go on into their practice?
Yeah, this is an interesting thought. I think there's this growing field of blank onc, like cardio onc, pulmo onc, renal onc, whatever, subspecialty, and all the cancer and cancer-related complications of both the cancer itself as well as complications of the therapy. And as interventional pulmonologists, we're really positioned well to provide comprehensive care for cancer patients that have any manifestation of their cancer or complications of their cancer or their cancer treatment inside the chest, right? We're very uniquely positioned for that. Mm-hmm. And I think part of it, like, for example, I think the thing that I run across so frequently now is, some of the immunotherapy related pneumonitis rates are pushing 20% in some of the clinical trials. So 1 in 5 patients up to can develop some sort of immunotherapy pneumonitis, but some of those may be pseudoprogression, some of those may be pneumonitis, some of those may be lymphangitic carcinomatosis. And I think we're uniquely positioned to be able to try to make that call and that differentiation and figure out who needs to get a biopsy to help delineate which one of those things it may really be, because it has such a profound impact on prognosis and treatment. You stop the systemic therapy and give them steroids and other immunomodulating agents, or do you continue the treatment because or change systemic treatment because it's progression and it's lymphangitic carcinomatosis? Mm-hmm. That's such a profound impact on prognosis and treatment. Not having a middle person make that decision and having to make a second referral really, I think, kind of streamlines the patient care pathway to getting a definitive answer and knowing what to do next. And I think we as interventional pulmonologists are very well positioned to step in that role to provide comprehensive pulmonary care for all our cancer patients, including the complications of cancer therapy. And I think that's something that may be a kind of real academic and clinical niche that will emerge more and more over time.
Scott, I look forward to seeing you at the next conference with your badge, which should say Dr. Scott O, Onco Interventional Pulmonologist. I look forward to seeing that. Scott, this was fantastic. I always like to leave some time open for closing remarks. Anything you feel we left out that's important to discuss?
I think as a specialty, we are moving more and pushing more into the therapeutic world. And I think what we need to be thoughtful and very mindful of is what is the gold standard that we compare our bronchoscopic therapy approach to, right? If you think about surgery, let's say, then the recurrence rate was 30% from the CalGB study. So, and then when we compare it to radiation oncology literature, we have to be really thoughtful about how they define disease recurrence, because in that post-radiated field, it's hard sometimes to see what's cancer and what's residual disease, et cetera. And so many medically inoperable patients were enrolled into those clinical trials that, the overall survival rates are so low because they have so many medical comorbidities. Mm-hmm. It's hard to know what the real control rates are. But I think it's really, really exciting times. Dr. Chang from MD Anderson, the radiation oncologist, just reported and published on their iSaber trial where they combined immunotherapy with radiation, and they had that resulted in significantly improved outcomes combining the therapy. And that's where I think we as a field need to quickly move to, figuring out if we're going to do bronchoscopic delivery of therapy, figuring out very quickly and moving towards combining with whatever tools we have in our armamentarium to put into that kitchen sink and throw it at the cancer to have the best long-term durable outcome. So I think that's probably the thing that is at forefront in my mind is we have to be really thoughtful how we design and define outcomes in our therapeutic trials.
Yeah, the horizon is definitely an exciting spot with what we do here. Scott, I appreciate your time. This was wonderful having you on today.
My pleasure. Thanks for having me, and see you at the next conference.
Sounds good.